regardless of how long you've been part of ALD Connect, or this is your first time here, you are part of ALD Connect, and please feel free to make this your consortium and let your voice be heard. What I thought I would do to kick this off is just tell you briefly about ALD Connect and have some have a brief update of research that has happened in the past year, because I always feel that that's what people are coming here for. They want to hear what's the latest in terms of research and thinking in ALD, and then we can kick off this meeting and thinking about gaps together. So just briefly, my disclosures. I'm still hearing a little bit of an echo here, Dean. Just, I don't know if others are hearing it. Okay, perfect. And I apologize to that side of the room, but I'm going to stand over here so I can see my slides. So for those of you who are new to ALD Connect, what is ALD Connect? It started 5 years ago as a consortium attempting to bring together all stakeholders in the field of adrenoleukodystrophy. The idea was that this task is greater than any one of us, greater than any individual academic center, greater than any individual patient advocacy group, or company for that matter, and that we really need all talents and all perspectives to make progress in this disorder together. And so the mission really is to improve medical care, to ultimately eradicate this disorder, and to do this together, not just academic groups alone, not just patient advocates alone, but really as a hybrid, as a group that's bringing together many talents. And we were very lucky to build on the ALS experience and the fact that the Northeast ALS had built a trial consortium over many years. They, however, had done this with academia alone, and we were trying to do this together with Alex Sherman's help in a larger field. So over the years, we've had meetings, we've had work groups. So we have a board that's composed of both physician scientists, patient advocates, and really is trying to assemble all the different perspectives necessary to make progress. So for those who are new to ALD, and I see some faces here who are really new to the field, I'm just going to give a brief overview of what ALD is. It's a single gene disorder that leads to a biochemical defect in very long chain fatty acids, but there are very distinct neurological phenotypes, and we're going to try to make progress across really the various different presentations of this disorder. On the one hand, cerebral ALD, the childhood form of the disease affecting the brain, white matter, and causing inflammation. On the other hand, AMN, most common phenotype, not affecting the brain as much as the spinal cord, where we see an axonal degeneration occur, and where we've also in more recent years recognized how much women are affected. And this is, I think, a very important recent insight, in large part due to Mark Engeland's work in Amsterdam. So just to point again to this phenotypic variability, you're born with, okay, here's the pointer. You're born with the gene defect, you have elevations in very long chain fatty acids, and then between the ages of 4 and 10, you have about a 30% chance of developing cerebral ALD. If that doesn't occur, you go into adulthood, and the most prevalent form of the disease is now adrenomyeloneuropathy. You still have a risk for developing cerebral ALD, but that becomes more prominent. And as we've learned recently, women can be just as severely affected, and by the age of about 60, a large majority of women also have problems with gait, with muscle tightness, and bowel and bladder problems. So just briefly to go over cerebral ALD and just describe this progressive course of the disease that really strikes boys in the prime of their childhood and progresses from attention problems, behavioral problems to affecting vision, hearing, speech, and ambulation. And on MRI, there's this distinct pattern where you can see the white matter progression occur, and we've come up with an MRI scoring system that many of you know called a LESS score that quantifies this over time. So that has been how we've thought about cerebral ALD in the past. I'm going to show you in this brief talk that actually things have changed and that we are really moving into an earlier pre-symptomatic stage. But just briefly to mention that we, for trials, use a neurologic function scoring system that captures various different domains affected in this disorder, everything from communication to vision to need for tube feeding or the bladder problems. And the major functional disabilities are here shown in bold. So a very nice recent publication by Troy Lund and Jerry Raymond showed the impact of hematopoetic stem cell transplantation upon cerebral ALD, and that has really for decades been the go-to modality to rescue these boys. And I think what was very nice in this recent publication was that beyond reporting on survival, which is often the measure that's reported most in the literature, they really focused on the major functional disabilities, really showing that actually here in gray, the major functional disabilities are affected to a far greater extent than just survival alone. And when you treat with a bone marrow transplantation, you can really rescue both survival as well as major functional disabilities, however, much more successfully so if you do it in the early stages of the disease compared to the advanced stages of disease. So I think an important paper and something that really has put this on the map and really allowed us from there also to move forward to another form of hematopoietic stem cell transplantation using ex vivo lentiviral gene therapy. And essentially how this works is instead of taking an allogeneic donor, you're taking cells from the boys themselves. You are mobilizing these cells into the peripheral blood, transfecting them with a lentiviral vector that delivers a healthy copy of the missing gene. And these cells then are given back to the boys after a brief amount of busulfan and cyclophosphamide and followed for a 2-year period. And that has been something that also exactly 5 years ago started here in the US. And this is really work that was very much driven by David Williams and Christy Duncan, who is also here today. And they were able to show that vector copy number is retained in all the boys treated at last follow-up, and that the faulty ABCD1 is now properly expressed in about 20% of peripheral blood monocytes, as shown on the right. So what kind of impact does this have upon neurologic function? Sorry. Oops. Can you go? Oh, sorry, other direction. Yep, got it. So in terms of neurologic function score that I told you about before, that Jerry Raymond developed, the effects that we saw after gene therapy were that most boys stabilized immediately after treatment. There was one boy who was rapidly progressing at the time of treatment and sadly succumbed to disease progression, this patient 2018 that you see here. And there was one more boy who developed some recurrence of contrast enhancement and underwent a separate bone marrow transplant and died after that. But the large majority of these boys have done very well and are doing dramatically different from the untreated historical cohort. I mentioned before that we are using an MRI scoring system in order to gauge how the disease progresses. This was something that Dan Less developed, and you can see here that depending on how large the lesion is, there's a Less score of 1 on the left, isolated to the splenium, and a Less score of 15 as the lesion grows and involves different areas of white matter. And one thing that we've been looking at in the trial very closely is the amount of contrast enhancement apparent. So how does that change over time? And what happens after enrollment of these boys that usually have a lesion within the corpus callosum? That lesion stabilizes at 1 and 2 years, which is dramatically different from what you see in the untreated condition where the lesion has spread into the white matter in the subcortical areas. Contrast enhancement present at baseline usually disappears at 1 year and 2 year. Again, very different from a garland of contrast enhancement you see in the untreated condition. So we've made progress in gene therapy, but I think one of the largest areas of progress we've made in the last few years has really been due to newborn screening and really the work of Lisa Seeger and many of the women depicted in the bottom right-hand corner, where we are really seeing now across the US newborns being diagnosed in a timely fashion at a time when we can still initiate therapies in a successful way. And really these children and families have options, which for many decades, a lot of these families did not have options as they only were diagnosed in a symptomatic state. As this landscape is now changing and newborn screening is rolling out across the US, and you can see all the states shown in green that have testing, and then those that are starting testing this year or next in orange. The landscape is changing, and we are now seeing a different form of the disease. And I think we're recognizing that different from what Hugo Moser taught me at Kennedy Krieger too long ago now, that the form of cerebral ALD we're seeing is not necessarily one of the large inflammatory lesion with a garland of contrast enhancement, but one of a really small lesion evolution that is something that we are struggling with in first detecting and then appropriately managing and acting upon. And this is really by recent collaboration with Patricia Mussolino, Paul Caruso at MGH, and Eric Malik at Cornell. And you can see these small lesions here within the splenium of the corpus callosum, just a tiny dot, grow over time. Another one here within the genu of the corpus callosum, the intensity rising. In many of these cases, we see growth of the lesion without the less score changing. And it's becoming quite clear to us that the less score is really not sufficient to capture the change that is occurring. Because you can have 4 times growth in your lesion size, and your less score hasn't changed. And how is that actually appropriately reflected? So I think important work that's happening by Patricia Mussolino now, MGH, is looking at quantifying perfusion changes in the brain, and you'll hear a lot more about that later today. So just a shout out to that important work that she's doing. So moving from cerebral ALD to AMN, clearly we need a different set of tools, we need different minds and different thoughts to apply to this, which is really the largest patient group in the US. Spastic paraparesis and extremities, walking balance difficulties, bowel and bladder problems, and how can we properly quantify changes over time. And really the group at Kennedy Krieger were the first to sort of think about this and come up with a staging based on weakness in AMN that distinguishes 3 levels of severity, and also acknowledges that gender differences exist but are more prevalent earlier at an earlier age rather than later, where they tend to be similar. Women tend to be similar to men. Beyond strength, balance is also a problem, and this is something that men and women share. Here work by Mark Engelin in Amsterdam, where he was able to show that yes, while women became symptomatic later than men, they were equally affected in balance and weakness, and had also problems with bladder and bowel control. So I think as we are rolling first trials out to men, we have to really be acutely aware of the disease burden that affects women, the fact that they're often taking care of their children, their boys, not thinking of themselves. I often have to remind the mothers that come to me for a separate visit just for them, because otherwise we're sort of not appropriately managing this. Work by our urologist Pablo Gomri and Camilla Kaur, looking at the amount of urinary and bowel symptoms in AMN, right now happening through surveys, also serial bladder emptying studies, but really showing that reports of urinary symptoms are about 60% of men, 60% of women, and bowel symptoms seems to be more frequent in women than men, which I think also reflects what is being seen in Amsterdam. Biomarkers in AMN, a very important topic when it comes to quickly instituting trials for AMN. Here, work by Ali Fatemi and Bella Turk, who unfortunately I didn't have a picture of, but he's really gone all the way from studying magnetization transfer abnormalities within spinal cord to here also now doing functional MRI studies. Very important studies that are hopefully going to capture some of the abnormalities that are very specific here to spinal cord. Letterio Politi discovered changes in spinal cord volume and showing that there was up to 40% differences in spinal cord atrophy within the cervical cord in AMN. And these, again, are markers that might help us more rapidly institute trials if we can change these measures. I think what people are most excited about this year is really the fact that a first worldwide AMN trial has rolled out, and big credit here to Minorix for doing this, and Aurora Pujol for doing some of the very early preclinical work on this. But the mere fact that in a rare disease we are able to have a worldwide trial that started across the Netherlands, Germany, France, and now has in recent months rolled out to the US, I think is terrific. I think there were up to 130 patients, I think, screened, and around 90 now enrolled. So I think that is something that is testimony to that it is possible, and that hopefully others also recognize this is a disease group to engage in and to build on. In the past year, we've also seen important new guidance for endocrine management in ALD following newborn screening. This is work from Molly Regelman, and I think important to highlight here that we really didn't know what to do with the newborns that were getting ACTH levels, and it was sort of a new field since many of the patients in the past had been diagnosed in later childhood. And she really helped to build consensus among multiple endocrinologists, showing that what you do at different stages when you have ACTH levels that are either too high or within a borderline range. And I think this is really setting the stage for nice progress in the coming years. A very nice study initiated by Irene Hoefnagel, Mark Englund in Amsterdam, in collaboration with MGH, where we've also been able to look at the lifetime experience of adrenal insufficiency, and I think up to 150 patients are in that range, and show that really adrenal insufficiency is the first manifestation in most cases, and one of the most prevalent aspects of the diseases across the lifetime. And she very nicely also mapped out the institution of glucocorticoid replacement and mineralocorticoid replacement. I think, again, a hallmark study that will help us now also target this aspect of the disease and see, can we do better over time? So what is missing? Where do we go from here? I think I've spoken in the past about the landscape of ALD, and that really in this landscape there are many different phases, different stages, and also different pathologies. Right now, we've really only successfully treated the early cerebral stage with inflammation with either bone marrow transplantation or ex vivo gene therapy. I'm very excited that a year after saying that, we now have AMN that is also being treated. But I think we still have so much more to do to treat advanced cerebral ALD. Even think about the early symptomatic stages and early pre-symptomatic phases of ALD, and most importantly, also the women. And that's where we need to do a lot more. So, what is missing and what new things could we be doing? I'm excited that there are new model systems and new ways to look at lipids. Here, Josh Bonkovsky has recently published a new zebrafish model that allows for rapid screening of new compounds and might allow us really to start new trials in rapid fashion. Stefan Kemp, working on lipidomics, a platform, really saying it's not just the very long chain fatty acid alone, it's where it is incorporating into, what are the kinds of different lipids that are affected by this, and are there things that are more specific and better biomarkers that would tell us when progression would occur. There's new biology, I think, to be discovered. There's dysfunction of monocytes and microglia. Ali Fatemi and KKI has shown that monocytes from cerebral ALD patients show much higher levels of TNF-alpha after very long chain fatty acid administration. We've also been able to show in the mouse model of AMN that the microglia themselves are more phagocytic. They seem to be enveloping synapses, enveloping neurons. So there's a clear dysfunction of microglia within spinal cord. Okay. So, sorry, just briefly, new treatments. Beyond ex vivo gene therapy for the boys with cerebral ALD, I think we're going to see in the coming years an intrathecal AAV-mediated gene therapy rollout. Recently, we were able to publish the success of this in the animal model, where we're delivering AAV-mediated gene therapy into the spinal cord of the mice and able to get into the right target cells, and also lower very long chain fatty acids within spinal cord. So we're excited about this. This has never been done before, and we hope we're going to learn more in the coming years. New data platforms. I think this is probably one of the most important topics we'll discuss, and something that we've all been aspiring to over the years. I know Ali Fatemi has tried to put together a larger consortium grants with me and also Adeline Vanderver, more recently through GLIA. These are important efforts that are trying to standardize measurements across different centers so that we can collect data together, that we can together run trials. Replication of data builds confidence in findings. Lack thereof prevents pursuit of ineffective treatment. Clearly, we're more attractive as a disease to industry if we have solid databases. Deep phenotyping, wearable devices, continuous recording, and even a few patients can point to new relevant outcomes. Brian Chandler and others have been managing our Facebook page and managing social media. I think that's very exciting. We see different successes in the world of cancer, Flatiron, a big data company, RDMD working in the rare disease space, and luckily we have Alex Sherman here who is very versatile in these things. So something we have to think about together. I think there are also pitfalls to big data, and I think as we go into this, one has to be careful not to be blindsided or just simply embrace the new kid on the block. Statistically measurable difference is not necessarily a meaningful difference. Aggregation of heterogeneous data can dilute and obscure effects. I would say one of the biggest advantages of a single gene disorder is its molecular definition, and sometimes that is lost in big data collections, as we have seen across many common diseases. Big data can help address important questions, but is rarely useful in generating these questions. So Alex and I always quibble over these things, and it's nice to have friendships where you can do that. So. I think one important way to address big data and what kinds of data we want to collect is to act upon FDA feedback. And I think here, really important work initiated by Rachel Saltzman, Jacob Keane at University of Utah, is to develop a patient survey methodology. And we've really been doing this with FDA guidance and feedback along the way. And I think we're finally ready to roll this out where through initial patient interviews and the methodology that Jacob Keane applies, we're able to understand what thresholds of disease burden exist and what the priority and perception of patients is in this process. So I think I'm about done here, and I apologize for going over, but I thought it was sort of important just to summarize what we've done in the past year. Alex Sherman will tell us more about later about the patient portal for ALD and AMN, but ultimately it's all about really your participation and what you want to see happen within the field of ALD. And I think we've built some of the tools that allow that, and this is clearly not just about some of the research and the science that I've shown you, but really about capturing some of the priorities of patients. And those differ greatly depending on what age and what stage of the disease you're at. And let us also remember that the disease affects the whole family. And so it's really the community that needs to weigh in as a whole. And I think there's a lot of room here within ALD Connect to be innovative and think about this in ways that have not happened before. So look forward to the next 2 days, and just want to sort of thank all the patients who have been really the most valuable part of all this. Thank you.